Whenever you have a mixed audience like this, in fact, I was just mixing up the slides because some of you are beginners, some of you are experts in the field. And so we have the importance, because this is an expensive device and all that you do, you should ensure that you have a maximal benefit. That's why case selection becomes very important. Nowadays, if you're a beginner, please don't venture into narrow QRS, RBBs, because if the patient has an adverse outcome, it can end up in a lawsuit after 7 lakhs and 8 lakhs. We have seen this happen. So some of them are basic things for physicians who are practicing device implants. One is these high output devices like ICDs and CRTs do not have lifetime warranty. So it is extremely important that especially in CRTs you optimize the output to conserve the battery. In regular ICDs, increase the AV delays to conserve the battery, turn on the hysteresis, and program the separate sleep rates for these high-end devices. We'll come to this. This is the projected longevity when you have a pacing output at 4, and the same patient, if you program it to 2.5, you extend the battery life by almost 3 years, which is pretty significant in these patients. And as far as CRT is concerned, it's been shown, at least in a couple of studies, that it is better to have patient's intrinsic P wave and followed by the paced biventricular QRS complex. So there is no sanctity that we should program it as a lower rate of 60. We can have it as low as 45 or 50, so that as far as possible, patient's intrinsic conduction goes from A sense to V pace, and it will be by V paced at that stage. And the only thing is here in patients, someone was asking about mortality benefit. Because our patients cannot afford, several patients who actually require CRT with a defibrillator end up getting only CRT. So with the result, you have an unprotected sudden cardiac death risk in this patient because you haven't given him a defibrillator because of financial reasons. So you should do everything possible to prevent an adverse outcome. And the single most thing is, Dr. JP did emphasize this, when you implant a lead, the measured R wave tells you whether you are in a scarred area or whether you are in a healthy area. You put an LV lead and you get an R wave measurement of 9 and 10, it's a good healthy area. Whereas if you put it in a circumflex scar, you are unlikely to get a very good R wave. The reason why this is important is when you pace within the scar, you can induce VT and VF. There are a subset of patients with CRT where the LV lead is proarrhythmic. And how do you avoid that? Very simple, measure the R wave on the table. If you get adequate R wave and a good pacing threshold, only then you do it, irrespective of whether the CT or MR shows whether there's a scar or no scar. Now, we'll move on to the other thing. In contrast to a patient with a regular pacemaker, where you would like to minimize the ventricular pacing, in a patient with a biventricular pacemaker, you would like to maximize the ventricular pacing. Now, the first thing when you get a CRT is the percentage of ventricular pacing. If you have a person who is not responding and he has got less than 90% ventricular pace, then you have some room to play with. Do you have any data to support this? Yes. Look at this data which suggests that even between 85 to 90, 90 to 95, there is a graded response in terms of survival and long-term probability of freedom from heart failure. So to optimize the CRT delivery for 100% of the time ensures that your patient is likely to be a good responder. What are the potential reasons? I wouldn't go into, all of you would have been kind of familiar with the repeated AV delay, VV delay optimization. We will just go on to the other aspects of ventricular pacing programming which will optimize the CRT delivery. The other common thing is the upper rate behavior. Unlike patients who have regular dual chamber pacemaker, patients with heart failure where you put a CRT, several of them are young patients. When they are active, you find they have a chronotropic response where the heart rate shoots up to 130 or 140. In them, if you keep a upper rate of 110 or 120, here what happens? The moment that guy starts walking, you find there is a loss of biweek pacing. When he needs the maximum cardiac output, he is in the maximum LBBB state and the heart failure will worsen. This patient, for all practical purposes, is a good responder, but he is a bad responder because of inadequate programming. Because this patient need an upper rate of 140 and it's programmed as 120, you find that the upper rate, the patient has instead of biweek pacing, it's ventricular sense. The other common problem in patients with biventricular pacemaker is out of the box setting is whenever there is a PVC, all of us are worried about pacemaker mediated tachycardia. So the pacemaker has an inbuilt algorithm. The moment it sees a ventricular response which is not preceded by an atrial response, it labels it as a PVC and extends the refractory period called PVAR. Look at what happens here. A sense by V, there is a single ventricular ectopic beat which extends the PVAR, and thereafter all the patient's intrinsic P wave fall in the refractory period. Because it falls in the refractory period, it doesn't trigger the AV delay, and therefore the biweek pacing is completely lost. So this patient is again a good responder, but turned out to be a bad responder because someone has left the PVC response on the pacemaker. The Medtronic box, out of the box setting is PVC response on, which is a detrimental for CRT, and the patients will lose CRT. The moment they have 1 or 2 PVCs, you will completely lose the biventricular pacing. What is otherwise a potentially useful device becomes a useless device because of frequent PVCs and PVARP extension. The other common problem in patients with heart failure is the problem of atrial fibrillation. Approximately a third of these patients have atrial fibrillation. Remember, basic things are still very common. Atrial fibrillation, for you to ensure CRT delivery, first is to block the AV node. Simple AV nodal blocking agents so that you get an adequate CRT. If despite doing adequate pharmacological therapy, you don't have good biventricular pacing, there is something called as a conducted AF response which can be triggered on by the pacemaker, where each time when there is a patient's atrial fibrillation and it starts sensing the intrinsic QRS, it will increase the pacing rate so that adequate CRT is delivered. The same algorithm is available as VRR, ventricular rate regularization, by another company. What happens is in atrial fibrillation, there is multiple impulses which comes into the AV node and the ventricular rate is fast. But if you start reverse pacing the ventricle faster than the expected rate, you produce a retrograde concealment into the AV node, and the AV node becomes refractory for the subsequent beats. And that is the rationale for this VRR. Remember, patients, unlike the old pacemaker patients, these patients have otherwise a normal conduction and they are likely to have retrograde VA conduction. And this is a patient with atrial fibrillation, rapid ventricular response, CRT delivery is 0. The moment you turn on the algorithm of ventricular rate response, the CRT delivery becomes 65% in this person. So there are good potential algorithms which you should be aware of when you implant a biventricular pacing before you call it this is a non-responder. The other problem is the AV and VV optimization, which Dr. Sharda did allude to. This is especially, I think she mentioned it in passing. One of the important criteria for a responder is a prolonged PR interval. You have a person with an LBB, but the PR interval is 140 milliseconds. Now imagine this patient. In order to optimize the CRT, you have to pace him at 100 milliseconds so that you capture the ventricle. Now in a person with a left bundle branch block, when you simultaneously pace the RA and the LA together, the right atrium contracts. After 60 milliseconds, the left atrium contracts, but you have simultaneously made both the ventricle contract, resulting in a truncation of the A wave on the left side. This is an important determinant why, even though patient has a left bundle branch block, if the PR interval is not prolonged, the patient may not respond. Now, am I talking out of my hat? No, the data does support this. If you look at patients who have responded in Miracle ICD trial, patients with a normal PR interval did not respond well compared to patients who had prolonged PR interval. Prolonged PR interval gives you an opportunity to optimize the AV delay, which otherwise is a problem in these patients. It does make a difference in terms of improving the cardiac output in these patients. The other problem is, do not believe the device, whatever it says. It has been created by a very expert engineer to kind of make management a little smooth. This is a patient, for example, who had repeated mode switch. What the device was thinking was that this patient was going into atrial fibrillation again and again, multiple episodes of mode switch. The moment the device goes into mode switch, it goes back to VVI backup mode. But then when you go back and see, is the mode switch correct? What has happened was, at the time of implant, this is the atrial lead, which is looking at the atrial electrogram and a far field ventricular electrogram. So when this patient runs up or the flight of stairs, it double counts everything and then falsely labels this as a mode switch, which is not the case. And therefore, he loses the benefit of AV synchrony, and this retrograde far field is not an uncommon situation. Conversely, this is another patient where there is no mode switch. Actually, if you look at the atrial electrogram, it's full of fibrillatory waves. But the device has failed to recognize this, and it's under-sensing, and therefore it is labeling everything as AR, AP, because it has failed to recognize atrial fibrillation. These two things are enough to make that patient a non-responder who would have otherwise been potentially a responder in this situation. The common error is, once you put a CRTD, you just believe what the rep has said as out of the box setting, a VF zone. That is fine. But what happens is, the device, it has been clearly shown that inappropriate shocks in these patients causes worsening of heart failure, and they will die a heart failure death instead of sudden deaths. So you should make sure that these patients' SVT discriminators are turned on. If it's a young patient with a hypertrophic cardiomyopathy, turn the onset criteria on, so that the sinus tachycardia is not mislabeled as VT. If it's an older patient with atrial fibrillation, put the stability criteria on, so that the atrial fibrillation is not misread as VT and inappropriate shocks are not delivered to these patients. In addition, simple pharmacological therapy to block the AV node in the presence of atrial fibrillation will be very useful. The ICD in a CRT is supposed to prevent only sudden cardiac death due to VF. But if you have a person due to ventricular tachycardia, most of these things you should be able to prevent by anti-tachycardia pacing. This kind of a rhythm doesn't require a shock. And these shocks in patients with heart failure are not benign. Every single inappropriate shock as well as appropriate shock has been shown to increase the risk of death, heart failure death in these patients, and therefore you need to program these devices appropriately, so that there are several pain-free algorithms that are available by every single device, and you can turn the discriminators on and the stability criteria on, so that the inappropriate shocks are prevented. So at least 2 zones in your ICD, both for separately for fast VT and VF. SVT discriminators should be turned on in every single patient, and have the duration of detection to approximately not 1 second, as most of the boxes have out of the box setting. It should be at least 5 seconds, and it should be delivering only for VF, not for fast VTs, most of which are terminable by pacing. So in these patients, ensure that you have at least 100% ventricular pacing, take care of the atrial fibrillation, know everything about the device before blindly believing the device, because these subtle things may make all the difference between a responder and a non-responder. So I think I'll stop with this, and we'll take more questions if there are any.
Thank you, Dr. Narasimhan.